Hello, everyone, and welcome to Recovery Matters. This is a semi-monthly show of Lowell House where we're going to explore some of the roots of addiction, how it affects the community, how it affects families, and all of the things that people are asking, and really asking us on a regular basis. So we'll have special guests every week, and we hope with this program that we'll get a lot of participation, a lot of emails and questions, and we'll help you deal with some of the issues, because in this disease, everyone knows someone. 2 out of 3 people have someone they know that has an addiction issue. So we want to help you not only understand addiction, but also to help deal with it and find the right resources. So we're very fortunate today to have some guests, and we will every week have some special guests here. I'll introduce them to you. On my right is the Superintendent of Police, William Taylor, Bill Taylor. And actually, this is something that the police and the fire department, our first responders, and places like Lowell House work a lot together on. We have great partnerships, and Bill will tell you a little bit later about what we're doing about some of those things. On my left is Peter Saing from the Lowell Health Department. Peter is an outreach worker and currently working on one of our projects along with the police department, one of our partners. Peter knows a lot about this issue in the community. He's also an educator and someone I think that's been very important to us in the community to help battle this problem. So welcome, Peter. And next to Peter is Maria Lucci. Maria is our Senior Director of Ambulatory Care at Lowell House. And Maria can speak to a lot of the issues that pop up in the clinic and the issues in the community that we all face. So we've got a real expert group of people here, and I think we'll start off by asking the question that everybody asks me: why Lowell? We have one of the worst problems in the state, I think 3rd worst in terms of opioid-related overdoses and opioid-related deaths. We have one of the worst problems in the country. So why Lowell? And maybe we'll start with the superintendent and talk a little bit about that and what our problem is, and why is it here in Lowell?
Well, thanks, Bill. It's great to be here. This is an extremely important topic for the city and the whole general area. So when I think about why Lowell seems to be more seriously affected than some other communities, I think some of the more logical reasons are we're a major population center in the Commonwealth. So we're the 4th largest city in increasing population.
And I don't think a lot of people realize that.
That's true. And the other thing about Lowell is it's a hub. So, for example, we are a large urban center surrounded by much smaller communities. And so we operate much the same as like a metropolitan area, only much smaller, obviously. Mm-hmm. So I think those dynamics come into play. The other thing is we're close to some source areas that people bring heroin into the Massachusetts and New England area, and I think the close proximity to some of those areas obviously is a disadvantage in terms of people having access to opiates, especially heroin. And then I think the other areas there's certainly a residual, chronic heroin problem in this community, as well as other urban centers around the country and certainly around the area. And I think those combination of factors together potentially make Lowell more susceptible. The other, I think, very important bit of information is the combination of fentanyl into the mix. So we have identified that Lowell, Lawrence, Lynn, this particular geographic area seems to be a source location for people that are trafficking, importing fentanyl mixture with heroin into this general area, and that's just an incredibly lethal combination.
Yeah, and Peter, we hear a lot about fentanyl.
We do.
What is fentanyl?
Fentanyl historically is a highly potent opioid pain reliever. Prior to this position, I worked in a retail pharmacy setting, and when I heard fentanyl, the only one I was familiar with was the fentanyl patches. And these patches were prescribed for folks experiencing long-term chronic pain, cancer patients, those in hospice care. But then working in public health prevention work and around this opioid issue, I'm starting to hear it being laced in our heroin. So acetylfentanyl is actually measured in micrograms. It shows you how potent it is. Everything is measured in milligrams. Mm-hmm. Fentanyl is measured in micrograms. And I do want to mention, when I reviewed some of the opioid-related deaths in the city of Lowell, according to the ME's office, the medical examiner's office, 2014, 40% of the entire opioid-related overdose deaths were attributed or related to fentanyl.
Wow.
And then
Now, has that increased over the past couple of years?
Yes, it has increased significantly. Looking at data from 2015, we are at 69%. Wow. Yeah. So we've been hearing about this over the summer of last year in 2015 about fentanyl-laced heroin, but then it wasn't, I was waiting on the confirmation from the ME's office, and then once I received that, I saw it. It was 69% fentanyl-related overdose cases.
Wow, that's quite a bit. Maria, we've, a couple of years back, we didn't hear much about the epidemic in Lowell. Why are we suddenly hearing about it now? Why has it suddenly increased so much?
Right. So as Chief Taylor and Peter have mentioned, fentanyl is killing people rapidly. There has been an opiate issue and there's been an addiction in the city of Lowell, but the rate that people are dying has increased significantly because what people are using is deadly and it's very dangerous. So people, don't realize, a lot of people who are addicted don't realize, what it is that they're using and how deadly and, how quickly it can cause an overdose. So quickly that first responders can't often get there in time, and that fentanyl, the way that it works, just in the body, it works immediately, and so people go into overdose much more quickly. Now, also wanted to mention that the fentanyl that is, on the streets in Lowell is typically synthetic fentanyl. So it is not, what is prescribed by doctors. It's being made, unfortunately. People, have figured out how to make fentanyl and lace it with heroin to make it cheaper and make it more accessible. So it is definitely a contributing factor as to why we're seeing so many deaths related to overdose in Lowell.
Now you think with fentanyl being so dangerous, addicts out there, people using drugs would say, whoa, wait a second, I don't want to use this anymore. This is far too dangerous for me. But yet they continue to use it. Why?
Well, one reason, addiction isn't rational. So people who are addicted to opiates or any substance, the part of their brain that really functions to think rationally is not online. So that's one reason. A second is that sometimes for some people that is an attractive factor. And actually, I have been told anecdotally that, I will go seek out what I have heard gives me the quickest high, the best high, and, could potentially somebody else has overdosed on. So that's scary, that's overwhelming for treatment providers, and I think for first responders and others that, there is an attractiveness to the fact that it's
some
potent.
Fascination with the more powerful.
Yeah, that it's potent, and so, and again, I think people who are addicted aren't thinking with a part of their brain that's really rational. It's more like survival at that point, so they don't want to be sick. They're terrified of the feeling of not having heroin in their system. So we'll do anything, and we'll use whatever is available. And fentanyl-laced heroin is what is available currently.
So some of the other things we hear and certainly see a bit, there are other contributing factors. For example, what about the prison population and the people coming out of Billerica? We know that probably 90% of them going in have addiction issues. How does that contribute to the issue in Lowell?
Well, I think that certainly when you have an addiction issue and you go through a period of incarceration, I know Sheriff Katusian is very much in the forefront trying to get people appropriate services while they are incarcerated at the House of Correction. As you know, the House of Correction, you're there for a short period of time typically. It's certainly less than 2.5 years. And it can be 30 days even. So while they're in there for that relatively short period of time, the Sheriff's Department does try and get them some services, tries to get them into some treatment. And I know that the Sheriff is very much interested in the chemical component of treatment, the Vivitrol, and I think that's really what they focus on. And so I think that's a good way. He tries to give people that have addiction issues, especially when it relates to opiates, tries to give them that kind of a buffer. So if they get access to Vivitrol, especially if they're using the injectable form, which you, Peter, you know much more than I do about, but that gives them a 30-day ability to leave the House of Correction and then try and assimilate, get into treatment outside the facility. And so hopefully, they can become productive members of the society and be of a benefit to their family. It doesn't always work that way.
No, and that's true. We're going to discuss that in a couple
And I also
of
want
minutes.
to mention, folks who are coming out of incarceration, they've been incarcerated for a period of time, which puts them at a higher risk for an overdose.
Yeah.
Right.
Because the tolerance factor, it only takes 3 to 4 days to reduce your tolerance. So imagine 2 years or 30 days. So a lot of times when we visit the Middlesex House of Corrections, a lot of folks have told me, yeah, a gentleman just came out within 3 to 4 days, he overdosed, and it was a fatal overdose because the tolerance factor is a major factor. So with the Department of Corrections linking individuals that are coming out to say kind of re-entry work and setting them up with Vivitrol or some sort of continuum of care, that prevents them from relapsing or getting back to maybe what contributed to get back in the prison in the first place.
That's interesting stuff, Peter. And it kind of it begins to answer some of the questions that we all look at. And one of the questions is this a young person's disease that we're talking about? Does it affect particularly young people? Is it all across the age range? What do you think, Maria?
I think addiction in general, anybody is susceptible to addiction. So, young certainly, but people who are, older as well. I think, what's out there is dangerous. So anybody who has an opiate addiction is at high risk at this point, is how I see it.
So we're calling it a disease now. A few years ago, people were calling it a bad habit. Why is it a disease?
So addiction is a brain disease. It really, like I was mentioning earlier, it affects the part of the brain that has the ability to make rational choice. So when I explain it to clients, I say, it's like if you had diabetes. It's like if you had, a form of cancer. It's like if you had Alzheimer's disease. This disease affects the organ of the brain, and by using, repetitively over, the longer you use, the more severe it is. Using repetitively on a day-to-day basis, it changes the biochemistry of the brain. And so no longer can you make the same choices as you did when you didn't have a substance in you. The good news is the brain recovers. It's similar to, I think of plastic, neuroplasticity. So the brain, with treatment, with medication-assisted treatment, with therapies, with different practices, can, fully recover. And I think that's why we use the term, addiction in recovery, because people recover from this. But I think it's important that we, not label individuals as just having a bad habit, or saying to them, well, why don't you just stop? I think people have asked me, why can't I just stop? Why can't my brother stop? Why can't my family member stop? What's wrong with them? They know how badly this can get. They've seen it. They've lost everything. So what's keeping them going? And that's the best way I can just describe it to people. Is like, it is not rational. They're not able to use that part of their brain while they're actively using. It's really more like survival. It would be, I equate it to, if someone told me to stop drinking water when I was thirsty, and even though I saw like, oh, water's so bad for you, and water's going to cause you to get incarcerated, you know what? When I'm really thirsty, I'm probably going to drink water. It's not much different than that.
Yeah, and so when you go into recovery and eventually, because I know it's not a straight path for a lot of people, it's kind of a crooked path, people go a lot. When you're in recovery, is that it? Are you cured?
No, I don't think, there's not a cure for addiction. I think the term recovery is a better term to use with people, because it helps them to realize that this is something that needs ongoing maintenance. So someone, with an addiction problem needs to remember on a day-to-day basis in some, way, shape, or form that they need to, stay on top of this disease and manage it. Just like if you're diabetic, when you have diabetes, you have to manage that illness. You can't just go eat all the sugar that you want to eat and not take your insulin and expect that you're not going to end up in the hospital.
That's right.
So when you have, the disease of addiction, you need to sometimes take medication. You need to sometimes be in therapy long term, and you need to go to self-help or do whatever it is that works for you to stay clean and sober. And that path is different for everyone. It's not identical.
Great answer, and that helps people understand, I think, what's going on. So the real question we have here, the real question we have here is, with addiction, if it's a disease, and a lot of times we compare it to diabetes, we compare it to any chronic disease that people have, the statistics aren't going in our favor. Why is it actually getting worse instead of better? And do we treat it like a disease?
I think our struggles with that is we don't treat it like a disease. I think the stigma is a huge part around medical treatment.
Yeah, talk a little bit about the stigma.
So stigma is a huge thing. Even in the pharmacy setting, hospital setting, I share my experience working in a pharmacy setting. I have many colleagues, pharmacists, professional folks who receive a prescription for Suboxone, which is a medication-assisted therapy, and kind of view the individual differently as a person who dropped off a blood pressure medication or a diabetes medication. And that's still prevalent now as well.
Right. So a lot of it has to do with attitudes.
Yeah.
We just interviewed someone the other day, a very prestigious member of our community, who asked the same question that people asked 10 years ago. Why can't these people just get off of drugs? Can't they resist? Well, I think from what Maria said, they really can't, can they? And it's a very difficult path to be able to do that. So one of the things that we do a lot and we talk a lot about is what are the solutions? How can we help? What is going to solve this major problem and stop people dying? And I love the statistic that you give, Bill, that last year in Lowell we had 0 homicides. Great work by the police, great work by the citizens. But yet we had 47 deaths. So what kinds of things are going to solve this problem? And let's try and go over a few of them. And I know several things are ongoing, and I don't think there's any community that's better at trying to solve a problem that's more cohesive than Lowell. So what are we doing to solve the problem, and is it going to work?
Well, I think, first of all, shows like this really take a large leap forward because we do talk about it, we discuss it, we're frank in terms of our identifying the problem, letting everybody know in the community that there is this issue, it's not going away. If we don't talk about it, if we don't get more people aware of the issue and involved in finding a multitude of different solutions to it, then it's just going to continue to operate in the darkness. And I have people ask me all the time, Chief, where are these overdoses happening? Aren't they happening in the kind of the locations that you'd expect it to be? You know,
yeah, back
in
alleys.
the railroad tracks and the back alleys and stuff like that. And I said, well, you know, unfortunately, it's happening there, absolutely. It's also happening in the house next door, as we call it, not only in the tenements in the back alleys, it's also happening increasingly in the residences with the nice lined long driveways,
Right.
with the lampposts outside. And I think that there's a realization now across the Commonwealth, and certainly in this community, that it doesn't distinguish between gender, doesn't distinguish between socioeconomic groups, doesn't distinguish between race. This is an equal opportunity disease. It affects everybody. The stories that we hear, people involved in this crisis, are heartbreaking. And they happen everywhere, you know. And so I think that's the first thing. The first thing is get more people aware of the issue, get more people involved from a multitude of different disciplines trying to identify potential solutions. And it's going to take a comprehensive approach from everybody working together, trying to slow the increase in the use of prescription opiates. That's the feeding end. That's the preventative end.
And certainly the governor's done a nice job on that.
Everybody, the governor has done a very, very commendable job in his leadership capacity in this issue. And then on the other end, you know, people like in the police department, we have to stop people from dying, right? And so that's why we carry Narcan in all of our police vehicles. We are doing things, I know you're going to talk about Project Co-op. So we have to attack this issue from every angle possible. With an idea that you want to do prevention, but you also have to, you know, do the immediate outreach and trying to get to the people that are in the throes of addiction before they succumb to this disease.
Yeah, Narcan. It's not like Chris Matthews here. Narcan.
Yeah.
Used to be very controversial. Now I know all the police
Right.
cruisers carry it, the fire department. What is it? We hear a lot about it.
Well, Narcan is, the way I look at it is a tool. Right, we want folks to get into treatment. We want folks to get into recovery. So Narcan is used as a tool to buy them extra time to get into recovery or treatment. A lot of folks I've spoken to mention Narcan as an enabler, right?
Yeah.
I want to quote
heard that.
I want to quote a physician just a few days ago. She said that theory, I'm going to toss it out. Narcan as an enabler, I'm going to toss it out. I'm going to use a person who has a peanut allergy, right? Let's say, here's EpiPen, just in case you have an allergic reaction. is that person kind of eat more peanuts or
Or find bumblebees somewhere,
or something like
right.
so. So I tossed that out. But Narcan, alas, is a nasal spray, the one that we're familiar with that DPH funnels the pilot programs that we can have access to. There's access to it in the CVS pharmacies and a few other pharmacies in the Lowell area. But Narcan really is an opioid antagonist. Fancy way of saying it blocks the opioid off, reattaches to the opioid receptors in our body, and pretty much revives a person who's overdosing of an opioid. What's so important about Narcan, it lasts 30 to 90 minutes, meaning this is not a special medication that, okay, you've overdosed, I've received my Narcan, I can go on my merry way. What happens is, once the Narcan wears off, that individual will overdose off the same batch of drugs they initially took.
So it doesn't solve the problem,
No.
but at least it keeps people alive.
It
and
does,
that's
exactly.
a major issue for us.
Yeah.
So let's talk about some things we're doing to help solve the problem. Maria, what about the co-op program?
So yes, so we're doing a really exciting program, I think, an innovative program, and one that we're collaborating with the police department and Lowell Health Department on. It's called the Community Overdose Outreach Program.
Got that right, good.
And what we're doing is we are responding to individuals after an overdose has occurred. So we have, a police officer, Kevin Garr, who's on the program, and he is, doing outreach along with Peter and one of our caseworkers, Louis Diaz. They are going out to individuals once they find out that they have overdosed, and doing outreach and trying to engage them into treatment. So I think it's very important that we're working right at that point where somebody, these are the people that are at risk. Already, I have heard there's a person on the list of people that they're trying to engage into treatment who has overdosed 3 times since we started at the beginning of March.
Wow.
So, these are the highest risk folks that we're dealing with, and they've been successful so far in engaging people and going and getting them to come into our facility at Lowell House, but also to detoxes. They're doing everything in their power to get them a bed at detox, get them in there, and then hooking them into treatment afterwards. So there are a number of folks that they have gone out to and done follow-up visits with who are receptive and really do want treatment. So and they may not have sought, they may not have been ones to seek it out on their own. They may not have come and made the call to Lowell House or walked in the door or called detoxes. They may have been too, distracted with other things going on in their life, but the fact that somebody went out to them, to their home, to wherever they are, and said, we want to help you, that matters, and that they've made choices that reflect that. So
That's terrific, and we've done it without a lot of funding for it, and we're hoping that it becomes a permanent program. But the national data shows that over 60% of the people that overdose say if they had someone to help them, they would accept that help. So I think we're going to have great success with that. What about prevention? Because, ultimately, if we don't do prevention, we can't stop the flow of people entering into the addiction area and becoming addicted. So what are we doing along those lines?
Well, I will say this, Bill, that the statistics indicate that the United States is 5% of the world's population, yet we consume somewhere between 80 and 90% of the world's opiate prescriptions, right?
Right.
So you don't have to be a rocket scientist to figure out that that's a problem, right? And so the level of opiate dispensing of opiate prescription drugs in this country has gone to the point where people very often, you hear incredibly tragic stories about kids or people, just adults, that get an orthopedic injury or some kind of a chronic illness, and they literally get prescription opiates to manage the pain initially, and then in some capacity they end up trading an orthopedic injury for a lifelong addiction.
Right. We
And
hear that
it's
so often.
tragic.
Yeah.
And you hear the stories from parents that have had to unfortunately bury a adolescent that's exactly the progression that happened. And it's just so tragic. So I think it has to be a realization in the medical community that this is a big problem. And that's how we're going to potentially be more preventative and stop the flow of people into this addiction funnel. So.
Also, I just want to add to it, yes, opioid consumption, right? If there's a demand for it, it'll be pushed out. So just like the tobacco era, talking about youth usage, middle school, high school. During the big tobacco time, I mean, during my time, 25% of high school seniors smoked tobacco. Fast forward to nowadays, it's way under 5%, maybe 3%.
And we've done a good job.
We've done a good job. So the public health prevention, that messaging was out there as a general public. The consumption or the demand was at the all-time low. But right now with the opioid consumption, I think is very high. I think you go to a dental procedure, you go to the ER for anything, the first thing you receive is a prescription for Vicodin or Tylenol with codeine. I've seen, working in the retail pharmacy setting, Vicodin and Tylenol 3 were considered fast movers. We had large jugs right next to us, next to our computer, because more than likely, these prescriptions will be filled, Vicodin, alongside with the blood pressure and diabetes medication. But I think the higher demand for opioids, and then in the medical community is, I guess unintentionally, but if they're pushing it out and people are consuming it, and consumer education is not out there saying, oh, I don't know, maybe I'll take an Advil instead. But if that education is not out there, it'll continue to where we are now.
So I think the new legislation bill that was just passed in Massachusetts, which limits the amount of prescription opiates that a first-time user can be prescribed, I think is going to go a long way towards helping, start to stop this problem. So I think there's steps are starting to, I think there's a realization both in the medical community and in the state legislature and the governor's office that this needs to be, addressed, and I think they've taken good steps.
Okay,
Yes.
we're going to continue this conversation at some other point because we are not nearly finished talking about this. We've got an exciting show in 2 weeks. It's going to be What If I Find Drugs in My Child's Room? What do I do? We're going to have Louise Griffin from Zach's team. We're going to have a number of people that will join us, and that will be an exciting topic. And we do want to remind you all that the Lowell House Gala is on Saturday night. Bill Taylor was one of our honorees last year. We're honoring Nikki Songus, but we're also honoring the mother advocates. And that's very good in terms of Joanne Peterson from Learn to Cope. We're honoring Melissa Wexner, who's a wonderful educator. And we're honoring Louise Griffin from Zach's team. All have had tragedies in their family, have gone on to make a difference. So please join us. Join us next in 2 weeks, but also join us on Saturday night. It's going to be a wonderful event. We're really looking forward to great band, great food, great atmosphere. We'll raise some money for new programs and pay some attention to the addiction issue. So this is Recovery Matters. We thank you for tuning in, and we look forward to seeing you in the future.